Great. Can everyone hear me? Awesome. Yeah, great. Okay, well, yeah, like Martha said, thank you, Martha, for having me. My name is Lincoln. I'm a physical therapist, board certified neurological clinical specialist, and I did a movement disorders fellowship in so kind of further specialized in that. And I am a physical therapist at Reactive PT in Los Angeles. We have two clinics, one in Los Angeles, one in Torrance, which is just south, which is where I'm based out of. And I also am the director of the Dystonia program, which we started in January of last year. It was sort of a position I kind of helped create. And so as part of our kind of neurological specialty as a clinic, we do see a lot of individuals with dystonia, which unfortunately, as we'll get into, makes us somewhat unique. But it is something that I have a real passion for, and I like to, work with people with dystonia, help them improve their function and quality of life. And I also like giving some of these talks to dystonia support groups. I've given two others this year and a few in the past as well. And I also am do some research and data collection for the programs we have at Re+Active and talk to other providers as well to try to kind of spread information about the diagnosis, the different types, and the sort of treatment options that are non-pharmacological. So we'll talk about that today. Let's see. Here we go. So yeah, I introduced myself a little bit already. Um, in the when I did a movement disorders fellowship, that was in 2021, 2022 through Reactive and UCLA movement disorders. So I gained a lot of experience during that time, sort of specializing beyond just neuro, sort of within movement disorders. And I worked with several people during that fellowship year with different types of dystonia, cervical dystonia, focal hand, foot, limb dystonias, probably the most commonly but also some more kind of generalized and also segmental dystonias, trunk dystonias, and things like that. So I have a pretty wide breadth of experience, but I'll talk about the ones I treat the most confidently. And during that time too, when I got to shadow some of the UCLA movement disorders physicians, I got to see kind of in the clinic how different treatments are done through medication or Botox. And so I have a pretty good breadth of knowledge about those treatment options as well. But the main kind of goal for today is to talk about some of the non-pharmacological treatment options beyond, from rehabilitation therapies, so physical therapy, occupational therapy, and psychology as well as personal training. So in terms of our clinic, that is kind of how we have evolved, and this is based on some of the evidence, which we'll get into. So we're going to talk a lot about like what are the treatment options for dystonia? What's the evidence base behind that? And we won't get too into the weeds science-wise, but I do think it's important to have a refresher or an introduction if you haven't learned a lot about it before, about the pathophysiology of dystonia, like what is really causing it. Just a brief intro to that, because that really sets the stage for, based on that information we know about what's going on in the brain and the nervous system, how can we sort of take advantage of that knowledge and use it to help people with their symptoms. So a lot of the research and evidence that's been done in different types of dystonia has sort of shown the value of not just physical therapies, but also lifestyle changes, lifestyle interventions, and psychological therapy and support as well. Not for everyone, but sort of an integrated team approach is sort of what we have for a lot of the patients that we see with dystonia. So not everyone gets all of these disciplines, but a lot of people really benefit from sort of this team approach where it's very collaborative. I work with occupational therapists and psychologists on a daily basis and we collaborate to kind of come up with an individualized treatment plan for patients. So that's sort of my background, and that's sort of what we do as a clinic, just to set the stage. And then just kind of briefly, just so you get a sense of what kind of experience we're talking about. It is, relatively less common diagnosis compared to some of the other diagnoses we see, just based on numbers. So Parkinson's disease, stroke, MS are all things that we see a little bit more commonly, but we have had, a good amount of people, about 46 since January of last year, people with dystonia that I've worked with. And some of them, we'll talk a little bit more about the integrated team approach I mentioned. 19 of them have been in this sort of integrated intensive program, which have been very successful. And I really, that's kind of my passion in terms of working with people. I enjoy that the most. So I mentioned I work with a lot of different types of dystonia, and probably one of the most common that we see now, just in part, unfortunately, because there are just not a lot of places to get help for that, is runner's dystonia. So I'll show videos and examples of plenty of different types, but just to kind of show, this is sort of an integrated program that we did of a runner who had runner's dystonia for about 6 months. And it caused sort of this movement you'll see on the left, sort of this involuntary, on the left side of the screen, kind of outward whipping of the heel while running. And then you can see this was after a month. We did physical therapy, occupational therapy, psychology, and yoga for 4 weeks. And that was sort of how much better motor control she got during that time. I followed up with her about 3 months after that. Could you guys see the video okay? Can you give me a thumbs up if you can see it? Okay, great. And then about 3 months after that, this was her running back at home. And you can see she kind of still is continuing to make strides, no pun intended, in her running. And so I just like to show that example, not because it's an extreme outlier or anything, but just to show this is actually the type of progress you can have with dystonia. I do kind of make it clear to everyone I work with that, I don't see physical therapy or any sort of integrated therapy even as a cure. I don't use that word, but recovery and improvement in your motor control, pain, range of motion, and just overall, functioning, being able to do what you love to do, including running, is definitely possible. And you can make kind of sustainable improvement. And these were during those 3 months where she was continuing to make progress. She was just continuing with the sort of home program that we had developed for her, individualized for her, and she was able to keep seeing progress sort of on her own. So that was kind of that's just an example to get started with. So I think, a lot of you kind of know a lot about dystonia. Not everyone does. We're not going to go too deep into the background of it, but I do think it's kind of important just to quickly review the science of what it is, because again, that helps set the stage for why treatment works and what the rationale is. So these are some of the different types of dystonia. These may be your diagnosis. You may have a different one entirely, but these are just some of the different types that we have seen at Re+Active. There's a lot of different types, and I'm going to try to, there are themes from everything that we're talking about in terms of the evidence, in terms of the treatment approach we use that is relevant they're broadly applicable. And I think I will be able to talk the most confidently about the ones that I see the most. But if you have any questions kind of about a specific type that you have or that you're curious about, I'm happy to answer that as well. I definitely don't think the presentation will go 2 hours or anything like that, but I want to leave plenty of time to answer your questions at the end. And I won't just talk at you the whole time. So this is for you guys. So a little bit more in the background. I really like this image from a paper in 2020 about dystonia, because this really kind of sets the groundwork for how do we treat dystonia beyond, just medications. And this is based on what we know about dystonia, which is that it is a brain and a nervous system problem that occurs and results in these abnormal contractions, postures, inability to control movement in a specific way. It can be all the time or, task specific, as in the case of like a hand dystonia, writer's cramp. More today, I think I see that with typing or playing a musical instrument, not really writing so much. But that's sort of focal task specific dystonia, or it can be more widespread. But these are sort of the things we know from this dystonia overview paper that are highly prevalent symptoms within people with dystonia compared to the general population. So I like the image because it does sort of show these are the symptoms. The movement disorder is the part that people see and notice the most. But when I talk to patients that I work with, a pretty high percentage of them will just also tell me and endorse a lot of these things. It might not be relevant to everyone, but balance problems, just overwhelming kind of fatigue, pain, sleep disturbances, brain fog even. We know that that is a component of it as well. There can be, psychiatric comorbidities. That's not nearly everyone, but those comorbidities may play a role in sort of perpetuating or exacerbating the symptoms that people do have. So I do think that, again, this informs the way that we look at dystonia and the whole person, not just the movement disorder. And again, I'll say, not everyone needs anything more than physical therapy, but a really high percentage of people do benefit from getting a holistic approach where occupational therapy works with them on sleep. Psychology might work with them on thought patterns and stressors that we know influence their symptoms. And I think the other thing people often tell me, even if they don't think, I don't know if I need, psychology, but I think a lot of people with dystonia will say, if I have cervical dystonia, when I'm talking to a family member that stresses me out, my dystonia gets worse. If I'm stressed at work, it gets worse. Or if I'm in public, I start thinking about the way my foot turns in and it gets worse. So it just kind of shows you the way the nervous system, the brain, and the movement that comes out are very interconnected. I promised I wouldn't get too sciencey and I won't, but I think it's just important again to emphasize that for most people with dystonia, unless it's caused by, there are exceptions, unless it was caused by a traumatic brain injury that caused specific damage or a stroke that caused specific damage. And even in those cases, this is true to some degree. This is sort of a software problem. So most people with different types of dystonia do not have sort of brain lesions that you could see on an MRI, but with sort of more high-tech imaging, functional MRIs, those are real-time brain images that look at the connections in the areas of the brain. We know that there are, real changes in the way that the brain is connecting. Those are due to a wide variety of reasons, and it's complicated. There are a large number of factors that all together are correlated, that are associated with someone developing a idiopathic dystonia, but none of them are, on their own enough to cause it. And so I don't think of it as monocausal, but there are a lot of different brain changes that occur over time. And the end result is that there's an overexcitation in the central nervous system that causes impaired sensory motor integration. That sounds really sciencey. It just means there's a problem between the area of your brain that processes sensory information in the affected area and then the area that produces the movement. And those areas connect to a ton of different other brain areas. So it's sort of a complex web in that way of things going on that leads to these changes. Neuroplasticity, I'll probably say that term a lot. If you are familiar with it, great. If not, it's essentially just the way the brain forms new connections, prunes ones that it doesn't want, and strengthens connections. And neuroplasticity sort of goes the wrong way in dystonia, and again, exceptions, but in most cases, that's how it works. And so that is how these kind of new connections form, and you have this new pattern of movement that is involuntary and not desired. So then again, just looking at the different brain areas, these are what we know from research into this, dating back, several decades even, but a lot more recently. The area that controls proprioception, the sense of where your body is in space. It's sort of an abstract concept, but if you think of it like, if you closed your eyes and put your hand behind your back, you don't need to look to tell that your hand's behind your back. That's what proprioception is. And that area of the brain becomes impaired. So it's almost like your brain is trying to control this movement in your neck or hand or whatever it is, but it can't really even tell for sure where it is. And so that's part of what leads to these unusual connections. I mentioned reduced inhibition. That's obvious. The brain is like not relaxing the muscles that should be relaxed in a certain situation. And so all of these kind of brain areas work together and unfortunately lead to symptoms. That sounds like a bummer, and it is, but the same way that the brain had these negative changes occur, we know that the brain is extremely plastic and highly adaptable. That's how we learn to do anything, learn a language, play piano, things like that. Those are all because the brain has this innate ability to change the way that it moves, to change the connections that it has. And so if your brain can learn the abnormal involuntary movement, we know that to a great degree it has the potential to unlearn that and sort of reestablish the normal kind of default connections that allow for more normal movement. Um, and so that's kind of our approach, is figuring out, okay, what are all the factors that led to these changes in the first place? How can we treat those? And that's how we try to help people. So that, again, this is sort of the approach, mind and body together. If you think of the iceberg slide, it's just about how do we kind of harness all these factors to help people make these changes. This is sort of an analogy that one of our other therapists came up with a long time ago for different neurological diagnoses, but it's, I think, extremely relevant in dystonia and a helpful analogy. Thinking of kind of your nervous system as sort of an environment, sort of like a garden. We're trying to think of all the different factors. What can we sort of control that helps your brain relearn most effectively? So that's taking care of your health overall, diet, sleep, managing stress, building up resources from a physical standpoint. So as a physical therapist, I work with that the most. There are changes that occur, I mentioned, in sensory processing in the brain. We can actually train that. There's changes that occur in terms of muscle flexibility, pain, posture. All of those things are things that we can address as sort of root cause things that, when treated, can help the brain sort of learn and reestablish, more normal movement. Yeah, so this is also, we will get into this a little bit more later, but I just like to show people how we sort of take a systematic approach to dystonia. This is something we've kind of changed and developed over the years, but it's something that I still use on a daily basis when I'm working with someone, whether in a team or just on my own, to help them find the right combination of things to help their nervous system flourish. So these are all some ideas that we might work on in terms of treatment, but it's also the way that we break down people's symptoms. So we talked about how there's all these different factors that can lead to the development of dystonia and the worsening or perpetuating of symptoms. And they're sort of lumping them into categories like this really helps us break it down. I think one reason that some people have trouble with rehabilitation for dystonia or other treatment methods for dystonia is that it is sort of a complex web of many factors, and it has to be really individualized and tailored to the specific person. Some people might not need, occupational therapy or psychology, but some people, when they have started to see a therapist, like a psychologist, is where I've seen their progress really improve the most. So not everyone has all of these categories to the same degree or even at all. But if we assess them in this sort of systematic way, we can take the system and then boil it down into the individual approach. We'll get into some examples of this. And then, so what is this treatment approach kind of based on? There, as I mentioned, has been actually a lot of research done over the years relative to a lot of other neurological conditions, though unfortunately not nearly enough, in my opinion. I think that's part of the reason for this gap in people's awareness of the treatment options for dystonia, as well as just in society. But I think also a lot of providers aren't aware that there are things you can do to help patients who have dystonia. I think many people have been to physical therapists before they come to Re+Active, and they'll say, my PT didn't really know anything about dystonia. Don't you learn about it in school? We don't. And actually, I think the main thing that is also unfortunately true for a lot of physicians as well. So people will also tell me that, I didn't know this was an option. My doctor didn't tell me. I don't think that's really, mostly like negligence on the part of the physician. It's just something that is not widely taught, which is in part the problem that there's not enough research. And so people just aren't aware of the option. But there is some research out there, and we know for focal hand dystonia, there's a great research led by a researcher named Nancy Beal at UCSF, not related, but I wish she's done really great research on sort of musicians' dystonia, writer's cramp, and other sort of hand dystonias on this sensory motor retraining neuroplasticity-based approach, which is really informs the way that we treat a lot of different things. So it's involving the sensory retraining, establishing normal movement. With these sensory variations, you're sort of making it a game-based approach, which is fun, but also is we know how the brain learns the best. The brain learns the best through variety, challenge, and incorporating a wide variety of different exercises and movements over time in a sort of blocked practice. We know that's how the brain learns the best, and so I think we apply that to treatment. So that's sort of what a lot of her research is about. We also know that uh, sensory training on its own, so neck muscle vibration, proprioceptive training, has a positive effect on cervical dystonia. And in general for cervical dystonia, physical therapy and Botox was, added an additional, I think, 20% of improvement during a 12-week, 12-week study period versus Botox alone. And there's other studies that have similar results. The overall result is that we know physical therapy and this sort of sensory motor retraining approach is effective. And then for the evidence for why we use an integrated team approach, going back to the iceberg, there are so many non-motor symptoms, and we know that behavioral therapy, non-motor symptoms like pain, sleep, fatigue, those are all things that can be assessed and treated by professionals, occupational therapies, therapists, psychologists, and so on. Some additional evidence, more evidence for a team-based approach, looking at the principles that multidisciplinary, holistic, psychologically informed treatment approaches were overall more successful in research studies compared to one therapy alone for many people with dystonia. Going back to the pie chart, I showed you the dystonia treatment pie chart before, and we talked a little bit about our treatment approach and how those things might be implemented in practice. These are some examples that I use with patients who have cervical dystonia, hand dystonia, or focal foot dystonias. And I'm going to go ahead and go to the next slide to show some examples. If you are looking at the slide or any of these and want to take notes or something, I can send you the presentation if you want at the end. If everyone just lets me know, I can email it to them if they're interested. These are some treatment videos in practice for people that I've worked with recently. So I'll just give you some examples of what this looks like. Looking at the pie chart, we can see, okay, sensory, motor control, the autonomic nervous system controlling your heart rate, your arousal, those things all influence the way that your symptoms can be. So I'm going to show you kind of mostly sensory and motor control, which is where a lot of physical therapy treatment mostly goes. So this, let me know if you're having any trouble watching the videos, but this was an external focus of attention with someone with runner's dystonia. And the idea was, from the last slide, giving them an external cue of try not to spill the rice out of the cup on your foot. So an external focus of attention is something that gives your brain a cue to accomplish a task versus thinking about an internal focus, which might be, okay, I'm going to try to walk and not let my foot turn in, which is what was happening to this individual. Her foot would go down and in, which is the kind of stereotypical pattern for someone with a foot dystonia. And just using this external focus helps the brain access this automatic movement of letting her toes actually go straight up the way that she wanted to. So that's the way that can be used in a lot of different types of dystonia, but it's kind of, it seems goofy, strange, but it actually makes sense if you think about it from a scientific perspective. This is another way of accessing more automatic normal movement in someone with runner's dystonia. So this might be a little hard to see. But so what she's doing is watching a video of my feet actually walking in the clinic, and she's holding it over her feet as she's walking. And so this is using the way that our brain can learn new movements, mirror neurons, and it lets her feet move more closely to how my feet were moving when she stepped. Uh, Great. And then I'll show you a couple more ones really quick. This is for cervical dystonia, a looking at change in position, which we know can influence dystonia. So people lying on their back or maybe doing like a side plank or lying or going on hands and knees, trying to turn their head, that change in position can sometimes alter the way that your motor control is. So here in hands and knees, this is much easier. And then the line also acts as an external focus. So she's got a head laser on. I didn't know if you saw that. So this is something we use a lot as a testing tool to see how well your brain can tell where your neck is in space, which we know is affected. But it's also a really fun, goofy training tool, which can be used to sort of say, okay, I'm going to try to keep the laser dot on this line rather than thinking I want to turn my head without it moving abnormally. This was an individual with a focal hand dystonia who had a sort of inward movement of all of his fingers when trying to type, and he worked in an office job, so that was obviously not an option for him. What you can kind of see here is he's got this yellow thing on his thumb. That's actually a block piece of putty. And when we use that, it just changes the sensory information enough to the hand that the brain was able to type for longer without it giving the dystonic kind of cramping inward motion that he had with it. So those are fun. And I think a lot of times people will say, well, that looks really good when you're doing it with those cues, but but then am I going to have to use a piece of putty on my thumb for the rest of my life? Or do I have to wear a head laser on my head for the rest of your life? No, that would be crazy. But it is definitely something that we know with accumulated practice, the brain can learn and make consistent long-term changes. And so I try to use the analogy of like training wheels on a bike, right? So you're using these tools that is helping you to initially learn how to do a movement, but only with that assistance. But over time, you eventually take the training wheels off and you have this entirely new skill ability that you never before practiced, but you had the tools to help you groove that pattern. And now you're able to ride a bike without training wheels. And over time, that can take a long time. Some people it's shorter than other. Like I mentioned before, there's a lot of variation in terms of how much, what percentage of improvement people will get, how long that takes. But in general, I think the overwhelming majority of people with dystonia can at least have some meaningful improvement. And with consistent practice, it gets better over time. We know that that's how the brain learns. That's how dystonia happens in the first place. And so it doesn't make sense to me to think that there's no way that it can be improved. So I mentioned the pie chart. These are the different components of it. I will just kind of give a brief summary of the programs we've done and sort of some of the data from those programs. And then I will go into another kind of treatment example, and it won't be too much longer. We can do questions after that. But so I mentioned this is the amount of programs that we've had. A lot of people will just see one therapy at a time. I see some people in a pretty standard physical therapy program. So I might see someone once a week for 12 weeks, maybe twice a week for 6 to 12 weeks, take a break, and then maybe see them sort of for check-ins or kind of a reduced frequency taper. So I have plenty of patients like that with different types of dystonia. But I mentioned a lot of individuals who come to see us are looking for that integrated sort of holistic approach. They have found that these non-motor factors are really big influences on their symptoms. And so we do integrated team programs for those people. This is pretty standard. It's about 4 weeks long, very intensive, of 4 times a week PT, 3 times a week occupational therapy, or once to twice a week of psychology, and then sometimes with yoga therapy or personal training as well. During those intensive programs, this is again something I kind of helped develop for dystonia over the past year and a half. But during these programs, we do once a week check-ins with all of the team together in a room talking about here's the individual's kind of main needs, here are their goals, how do we help get them as close to that in the 4 weeks that they're here. Some are as short as 1 or 2 weeks, some are as long as 8 weeks. These are often for people who are coming from out of the area and or out of the state or out of the country even. So we have had in the past couple of months people come with runners dystonia for a 4-week program from Kansas, Massachusetts, Australia, Florida, and Northern California. So there's a lot of people coming uh, from out of area. And so in that situation, we do this, the intensive model works really, really, really well. But I think it also works really well even for people who are nearby. And then it's easier to have sort of a taper afterwards. So they have this intensive program. We give them a discharge summary, which is sort of, this is the tour guide to dystonia, but this is the guide to your dystonia. Here's all the things we found from each discipline that are most helpful for you, that we think you should continue seeing progress, and we can help them in that way. If people are out of state, unfortunately, we can't do telehealth outside of the state that we're in. So unless they're in California, we can't do telehealth check-ins in that way. We can do it if they're outside of the country. Yeah, I have no explanation for that, but that's the way it is. But even with those individuals, we do continue following up with them. So options are, for example, we might collaborate with their physical therapist back home, do a Zoom call, do a sort of unbilled co-treat, and say, here's some things that you can, if you don't know a lot about dystonia, here's some things we worked with this person on, and you can continue working with them on that, plus the discharge summary. And then we can do, for people who are in California or in the area, do sort of a taper where they might come in once a week, once every 2 weeks for an additional 1 to 2 months. Yeah, so that's part of how it goes. And during those programs that we've had, the intensive programs, so average of 4 weeks, I mentioned between 2 as long as 8, but the majority of people are in that 4-week range of intensive therapy, which is based on some of the studies we've talked about already. Just to give a sense, so the average participant in those programs with any type of dystonia, at the end of those 4 weeks, we asked them to rate their subjective improvement during that time. And because of the different varieties of dystonia, it's hard to have a lot of specific objective outcome measures to say, how much better is the dystonia. There's a lot of different types, but in general, patients have rated just what is your overall sense of improvement compared to when you started? And the average has been about a 6.2 out of 7. So 7 is the highest score on the patient global impression of change. A 6 on that scale is better and a definite improvement that's made a real and worthwhile difference. So the average is a little bit above that. This is not, an advertisement for reactive PT, but I really like to share this to show people, the people who come to work with this sort of holistic team-based approach, who even just do physical therapy, who get rehabilitation for their dystonia, they do have a real meaningful difference. And that means that for, again, it's not a cure, but these people have already seen a good amount of progress. And we know that the people we follow up with continue to see ongoing progress in the long term using the tools, the exercises that they learned with us, again, at Re+Active. So just to give you, hope and just knowledge that there is a real improvement that comes with this type of approach. And for cervical dystonia specifically, the Twisters is a good comprehensive assessment. It's the it's actually an acronym, amazingly, but it's looking at what is your overall kind of level of disability, pain, and limitation compared due to the dystonia. And so on average, with the people that we've seen over the past since January 2023, people have an improvement of about 18.3 points on the scale. So a higher number is less desired. So a lower number is better. and they averaged a rating their pain baseline going down to about up on a 2.5 points down on a scale of 10. Their overall assessment of how well can I do the specific activity goals that I rated. So we'll say, how well can you do X goal that you'd like to be able to do? Cooking, running, working without pain. And they'll give a score on 0 to 10 scale. And then at the end, they reassess. On average, out of all those activities, it started at a 2.7 out of 10 and ends at about a 5.8. So it's not like, these people have no problems anymore, right? But that is a really meaningful improvement. And again, they feel the confidence that I can continue to make these changes on my own. So I will just kind of go, I mentioned some of the program specifics, the team that we have collaborating with your movement disorders neurologist. And then I'll just show you kind of an example program that someone who came with cervical dystonia and sort of how we approached all the things we already talked about. And then mostly after that, I should be able to take a lot of questions. I'll show some more videos too. So this is, again, the pie chart for assessment. As the physical therapist, I'm going to be looking a lot at sensory processing, JPE here, that's the head laser test where we're looking at how well can you tell if with your eyes closed where your head is using the laser as a cue. I'm assessing that. I'm looking at the vestibular system, so the inner ear. There's a lot of vestibular problems that occur related to cervical dystonia, and that relates as well to eye movements, so oculomotor movements. We're looking at that. The visual system is very related to the inner ear and the neck in helping the brain determine where the head is in space. We're looking at traditional physical therapy things like nerve tension, muscle mobility, motor control, things like that, as well as heart rate variability, so the autonomic nervous system, and all of these other lifestyle psychosocial factors that psychology might be looking at as well. Again, not everyone is going to do all these different disciplines, but I do think the holistic approach is important to at least learn about. So here's an example. This is JD, came from Indiana with cervical dystonia for about 2 years. The dystonia that he had caused a sort of backwards bending of the neck that was pretty, it was pretty strong. It was not really able to look straight ahead or down for more than, I don't know the exact number of seconds, but it was very brief, which was really limiting for him. He was super active before this had happened, hiking, lifting, reading. Even the less active things like reading and playing guitar were really, really difficult for him and caused a lot of pain, tremor. And he was also working as a in a auto assembly factory, and his job required a lot of head movements up and down, side to side, placing things down on a belt. And it was very kind of rapid movements, and that was becoming nearly impossible for him. So this is sort of the pie chart that we kind of developed with him, with his input at the start of the program, looking at here's the different things from our assessment we found most seem to influence your dystonia. And then that, again, informs sort of the treatment that we're going to be looking at. So we'll get into that just to give an example. So we're looking at, this is, for physical therapy mostly, these are calipers that we use to look at 2-point discrimination, which is a sensory modality that we know is affected in people with dystonia wherever it is across the body. So that is something we can assess and then reassess to see, okay, actually, is your brain actually improving at being able to tell what's going on from a sensory perspective in your body. We look at balance, we look at head writing reactions, the ability to just assess how does your brain figure out where your head is in space and what helps it to do that. Position changes, as I mentioned, can you have better control in a certain position? If someone has better control with their head in supine or using their different sensory tricks, that's a starting point. And then we can sort of build from there. Maybe we can try things then in quadruped, hands and knees, side lying, reclined seating, and then we can gradually take away some of those position changes and sensory inputs that help people early on, and then again see that improvement over time. Mentioned some of these already. We'll look at what his program consisted of. So this was 3 times a week PT, psychology once a week, occupational therapy twice a week, yoga therapy once per week. Occupational therapy worked a lot on specific activities of daily living, looking at how can he take tools from PT, from psychology, from the autonomic nervous system, and integrate them into his daily routine. Sleep was also another goal that he was having trouble with. And so occupational therapy did an awesome job helping him get a much more regular sleep schedule, which we know from research, but I can say anecdotally is often a huge factor. Managing the way that stressors influence his nervous system. So the autonomic nervous system, again, I mentioned it before, but that's sort of our sympathetic fight or flight part of the nervous system, or parasympathetic, that more rest digest. So looking at what is the balance between these sort of very kind of stressed fight or flight, heart rate increasing part of the nervous system, and what is the more relaxed part of the nervous system. It's always a balance, but we know in people with dystonia, they tend to have a sometimes very large imbalance towards the sympathetic fight or flight mode of the nervous system. And that is one of the reasons why certain things like breathing exercises, or for some people, it really varies what their regulating activities are. It might just be a walk in nature. It might be breathing. It might be meditation. It might be yoga. And I think I've had a couple of people tell me, Lincoln, that sounds a little woo-woo. And I could see how maybe it does, but it's actually based on the physiology of your nervous system and the way that when you are stressed, that has real physiological changes in the nervous system that up your heart rate, that cause your muscles to be more tense. And obviously, that's going to have an effect on your movement symptoms as well. So that's sort of the different types of tools we looked at. Some kind of treatment examples for JD. So we looked at modifying posture. We looked at sensory inputs. Remember, that was a big part of his pie chart. And so this was sort of one way of combining a lot of different things, as well as an external focus in occupational therapy. So sitting on a ball, we noticed that he actually had much better control of his head versus standing or sitting on a chair. And then he's holding, you can't see it, but he's holding a vibration ball on that part of his neck as well, which also helped him to hold his head straighter for a lot longer than otherwise. So that bouncing on a ball seems funny, but it actually gives input to the vestibular part of your nervous system, and that can help, for some people, their brain figure out where their head is in space more. Another kind of fun sensory tool that worked for him too, actually, was this cooling towel around his neck, which that was one of the things he could take back to work, and that actually really helped him keep his head straight for longer. Different people have different sensory tricks. I could do the same thing with someone else and it wouldn't work. That's why the individualized approach is so helpful. And then this sort of skull cap thing he wore for a while that also for some reason worked as a good sensory cue. You're just changing the input to the brain, and that can change the output from the muscles. And this one way of helping it to retrain. This kind of variability and practice is another thing. So here you can see he's using the laser, sort of tracing the star pattern with that external focus, helped him to keep the head straighter longer as well. One of his big goals was being able to walk downstairs without his head kind of tilting back. And so here he's got his cooling towel, very stylish, wrapped around his head. And then he's dual tasking. So I think he was listing classic rock bands because he knew a lot about that. And that as a dual task actually also helped his brain kind of relearn the normal movement with less focus on the individual symptoms as well. So that's just some of the kind of examples of different treatments that we do. And yeah, this is just, JD talking about the sort of improvement that he had while working with us. So again, this is not, to say everyone needs to come to Re+Active. I don't think that that's the case. I always try to find if there's other options for people to see people, providers who are experienced with dystonia. There's often not a lot of those things available, but I wish that there were more. So one thing we do at Reactive is to try to, beyond talking to people with dystonia, we try to talk to providers as well. So we have a group through Reactive called Brain Bites that is a group of providers, so physical therapists, occupational therapists, psychologists, speech therapists, and even physicians from around the country, actually some out of the country as well, that we have monthly meetings. We pick specific diagnoses and case series, case examples, and we talk through them and we show here's kind of the approach that we use, the science behind it, and sort of help. That's our main way right now of trying to help educate other providers. Here's some things for dystonia that you can do, so the next time someone comes in to your clinic, you don't just say dystonia, I've never heard of that, yeah, I don't know her. It's more like you can say, actually, I know what dystonia is, and I have some things that I can try. And so we're trying to sort of spread the word. I think the fact that we have people coming from out of the country or from across the country to see us, I feel incredibly, you blessed to be able to work with those people and meet them and work at a clinic I do. But it does really emphasize the lack of availability of providers who know a lot about dystonia, who can help people. And so I think that that's part of why people are not always aware of the different treatment options. So there are some other therapists out there who have experience. And I think what I try to tell everyone is that if you have a physical therapist that you like and you trust, but they just don't know about dystonia, but they're willing to learn, that's all you need. It's not rocket science. It is, you have to take some time to understand the rationale behind the treatment and to be extremely creative, which I think everyone at Reactive, that's part of what drew us there, is the challenge and the creativity that comes along with it. But if you have that person that you could, engage and enlist in your care, I think we always are trying to make that possible as well, and help people learn about it. So we do sort of some consultation at times, if you have another kind of physical therapist that you're interested in. The last thing I was going to say, I do see a lot of people over telehealth as well. So if you're, specifically, have questions about your diagnosis, looking for providers, or, potentially interested in, seeing someone via telehealth, I can help you find the right provider or otherwise. So um, that was kind of my whole presentation. I guess I talked faster than I meant to, but I have, like I said, we can definitely give you all the slides if you're interested in seeing that with the videos and stuff. But I guess if it's cool with Martha, I'm okay with opening up to questions as well.